I welcome everyone back, and today's session will be moderated by my friend and colleague, Sarah Blake, who is the director of the social science program here at the Radcliffe Institute. She's a professor of public health policy at the Harvard T.H. Chan School of Public Health and the vice provost for special projects at Harvard University. Welcome, Sarah.
Good afternoon, everyone. Thank you so much, Mac, for the kind introduction. It's great to be here. I hope you all are enjoying the afternoon. I love this annual gender conference, and so it's great to have a chance to be with you all. So this morning, we heard about the critical overlap between public health and mental health, as well as the importance of mental health for adolescents and gender groups. And we just heard a keynote about the need to drive forward on progress. So with this panel, we're going to widen the aperture even further, and we're going to focus on social justice and gender and mental health. And one thing that we probably all agree on is that our society is deeply inequitable. And that is not by accident, it is by design. So there have been deliberate efforts to keep historically underserved individuals at the margins of society. For example, we know that Black, Latinx, and transgender individuals with mental health problems are more likely not to get access to care. We just heard about that during the keynote session. We know that Black people are more likely to be diagnosed with schizophrenia and hostile behaviors than white individuals. And we know that transgender individuals have higher rates of suicide than cisgender youth. And we heard about that during the keynote as well. The list of inequalities in mental health goes on, and it has been made worse by the COVID-19 pandemic. Because mental health resources are inequitably distributed, we must focus on social injustice because we have to address the poor mental health outcomes. And to put a finer point on that, the current mental health system works the way it is designed to work. And so in order to change the design, we have to use a social justice lens to push forward toward solutions that are going to make a meaningful difference. And so today, we have the pleasure of hearing from another exceptional panel who's going to help us dig into social justice in 3 areas: reproductive health, climate change, and transgender health, all things which affect mental health. And so the 3 panelists that we're going to have the pleasure to hear from are Dr. Amutah-Onukagha, the Julia A. Okoro Professor of Black Maternal Health at the Department of Public Health and Community Medicine at the Tufts University School of Medicine, Dr. Chase Anderson, Assistant Professor of Child and Adolescent Psychiatry, University of California, San Francisco, and Dr. Van Susteren, a Clinical Associate Professor of Psychiatry and Behavioral Sciences at the George Washington School of Medicine and Health Sciences. Like the other sessions, each panelist will speak for about 10 to 12 minutes, then I'll moderate a discussion for about 15 minutes, and then we welcome to take your questions. At any point during the panel, please feel free to submit questions. I'll be filtering through them. And whether or not you are watching online or if you're here in person, please use the Slido link that's provided on the screen, and that will allow you to enter into the add questions. So with that, it is my pleasure to welcome Dr. Amutah-Onukagha to give our first presentation. Thank you.
Good afternoon, everyone. Thank you to all the organizers, and thank you to Harvard Radcliffe and Dr. Sarah Blake for having me here today. I'm really excited to chat with you about something I'm so passionate about and a lot of the work that I've been doing in the space of racism and maternal health inequities. So how many people have been keeping up with the latest data around maternal health? Anybody realize and recognize and scared shitless that we're in a pandemic here around maternal health and that the rates went up 40% in a year? So the maternal mortality rates, the maternal mortality rates for non-Hispanic Black women in the United States are quite high. I remember giving talks like this time last year, and I'd say 55.3 per 100,000 live births. Now it's 69.9. And the rates are actually increasing quite dramatically. And then when you look at it by age, it's even worse. So this is the latest data we have available. It was released in February of this year. So, thinking about pregnancy-related deaths versus pregnancy-associated deaths and the impact of maternal mortality, we know that there are racial and ethnic disparities in pregnancy-related mortality. And if you look at the data here, this is from pre-pandemic, then early pandemic, and later in the pandemic. But what it exposes is things that we already know for those of us that work in spaces around social justice and public health, is that whatever is happening in the pandemic, ideally the way racism is operating, is also showing up in the way that maternal health is delivered in this country. And so the rates of pregnancy-related deaths increased across all racial groups, but non-Hispanic, American Indian, Alaska Native, as well as non-Hispanic Black had the highest rates of increase. So there are groups called maternal mortality review committees, and in the MMRCs, they look at case study data, they look at decedent data, they look at abstractions, and to see if this maternal death could have been avoided, what happened in this case, and was racism and discrimination a factor. And we know that the majority of pregnancy-related deaths occur sometimes during pregnancy. The majority are around the day of pregnancy or 7 days, but then you see 53% in the postpartum period. So I think this is a window of critical intervention as we think about how do we address maternal health inequities and where are the days and windows of opportunity. It's during pregnancy, postpartum, and even in the prenatal period. We have the opportunity to intervene at each of those windows. So this is what I was kind of alluding to a minute ago. When you look at it by age, we know that Black women experience disproportionately higher rates than any other group in the United States. As I mentioned earlier, the latest data we have is 69.9. But when you look at it by age, particularly for Black women ages 40 and over, the rates are quite high. It's actually almost 8 times higher than those for women under 25. And you'll ask yourself, well, why are the rates so high? What are we seeing that's happening by age? Well, what's happening by age is the physiologic response to stress in the body. We know that Black women's bodies are 5 to 7 years older reproductively than their white counterparts. And this is due to the way that the body responds to stress. This is cortisol, this is allostatic load, this is higher blood pressure rates. And so these things all weather the body. So if anybody here has heard the term weathering, but it creates an opportunity for the body to be weathered, which increases the likelihood of complications and also increases the likelihood of low birth weight or a preterm birth, as well as maternal complications and maternal morbidity and mortality. So the reality of racism across the lifespan, we know that Black women sit at the intersection of race and gender. And I think oftentimes when we look at it, it's important for us to extrapolate what do those things mean individually. We're fighting a battle for maternal health, which sits at both the racial and gender intersection. And we know that this type of stress from being in an intersectional space for Black women cannot be avoided, ameliorated, eliminated by higher socioeconomic status or education. And I was giving a talk earlier, and I said you can't income your way out of racism. There's no amount of racism, there's no amount of income that can protect or completely buffer Black, non-Hispanic Black women in this space. Thinking about some of the cases that we've heard that received a lot of high-profile attention, like Serena Williams, and the complications she experienced during her postpartum period and her pregnancy, and the fact that she almost died from preventable complications because she was experiencing a pulmonary embolism and was disregarded and dismissed by the healthcare system and the nurses that were treating her. So that's the impact of racism, and that's how it shows up in the delivery of maternal health. So the MMRCs across 36 states looked at why do we have this variability in the risk of death by race or ethnicity, and it's due to many things. Primarily it's the ability to access care. Where do Black and brown women get care? The quality of the care that they are provided by geographic location. So there are parts of Massachusetts that will be considered a maternity care desert. There are many parts of the country that Black and brown birthing people in general are not able to get to timely care and to receive adequate prenatal care. They have to travel further, and we're seeing less providers and more demand for obstetric care. So this is quite the situation. USA Today did a nice 4-part piece on this last summer that I was profiled in, looking at rural and maternity care deserts across the country and how that's impacting the rates of maternal inequities. Also thinking about the prevalence of chronic diseases and what does it mean to show up with gestational diabetes, gestational hypertension? How is that patient going to be prioritized? What is the type of care that they're going to receive? And what does this mean for their potential outcomes? Looking at clinical and non-clinical support, we know that the role of nurses is critical. We know that having culturally competent and culturally congruent providers makes a difference. We also know that thinking about the role of doulas and midwives can be tremendous assets to changing the narrative around maternal health. And then structural racism. The way that structural racism plays out in the delivery of healthcare is racism is a system. And racism, and it's not one or two bad actors that really can make a difference. It's the policies, it's the procedures, it's the way that the system functions. And it's not enough to just say, okay, we're going to do implicit bias training or we're going to hold people accountable. These people are still actors within a system that is racist. And in that space, this is how the insidious nature of racism is able to thrive. It finds the corners and the nooks where people don't address it, the microaggressions that go unresponded to, and it just gets more and more life and continues to negatively impact minoritized communities. So thinking about the social determinants of maternal and perinatal outcomes, as a public health person, I'm always thinking about the social determinants of health, right? How does someone's place of residence, opportunities, education, transportation, income, what do these things mean for their outcomes? And we know that racism and discrimination are at the heart of those opportunities or lack thereof. We know education, food, the neighborhood and physical environment, the ability to access quality and timely health care, all play a role in reducing or exacerbating maternal health inequities. And so we have to think more critically and more broadly about how to remediate this and how to provide solutions. If we're only looking at the clinical space, we're missing opportunities. If we're not examining people's place of residence, people's place of education, the opportunities, the safety, the quality of housing, the nutrition access, these things all play a key role. And so if we're not looking at them, then we're actually missing opportunities for collaboration and to work together to really move this work forward in a way that's going to ultimately have a really pivotal outcome. So thinking about why some of the pregnancy-related conditions that lead to some of the things that we're talking about today, we see a really big impact. And I know this is going to come up in the Q&A later around mental health and the ability to impact mental health resources or to access mental health resources by pregnant and postpartum birthing people. That accounts for 22% of the maternal death that we see. And that's whether suicide, substance use disorder, hemorrhage is also a big role. We know that 90% of maternal deaths due to hemorrhage are actually preventable. And so that provides another opportunity for key intervention. Cardiac and coronary conditions, thrombotic embolism, and hypertensive disorders, such as preeclampsia and eclampsia. These are the leading causes of death. And these are the things that are really quite exacerbated in Black and brown communities, and I think the places where we could have the most inroads and save the most lives. So quickly around maternal mental health, we know that women experiencing depression have 40% greater risk of hypertension. Women with lower socioeconomic status are 11 times more likely to experience postpartum depression. And think about it, for most people, they're navigating the journey into parenthood or motherhood is already stressful enough, and then you couple that with limited economic resources, and it is a quite stressful situation that can produce anxiety, depression, and is not optimal for most people, primarily for people of color who are more likely to be in these situations. We know that 60% of BIPOC mothers lack access to prenatal and postpartum services. We saw that this was even higher during the pandemic when a lot of services were moved to telehealth capacity and ultimately results in stressors that may further impact maternal mental health. So we have a lot of work to do, but I think half of the battle is acknowledging the ability to locate resources and to have providers that can properly treat and accommodate Black and brown birthing people, both in pregnancy and a postpartum period. I think we have a real window in the 4th trimester or the postpartum period in getting postpartum care, postpartum doulas, really maximizing that postpartum visit with the focus on mental health and postpartum depression. So talking about reproductive justice, I run the Center for Black Maternal Health and Reproductive Justice at Tufts, and in that space we are really focused on eliminating maternal health inequities and providing opportunities for Black and brown birthing people to thrive. We're an academic-based but community-focused research center, and we really highlight the work around reproductive justice. So for those of you who are not familiar with the term, it's the intersection of reproductive rights and the social, political, and economic inequalities impacting a birthing parent's ability to access quality reproductive care services. And we focus on many different things: birth equity, reproductive justice, culturally competent care, working with providers, clinicians, doulas, and midwives, as well as providing opportunities for holistic maternity care with the focus on research and data around healthcare delivery. So the center has 6 units in total. We're about a year old. The Mother Lab, which I'll talk about in a minute, which is my students. I have 35 student trainees from across the country, undergrads, masters, doctoral level, nurses, public health practitioners, OBGYNs who are focused on eliminating maternal health inequities. I also have a research development and grants unit, a policy unit, a data unit, a community engagement unit, and a focus on education and training. We have 3 overall goals for the center. 1, collective action, being of service to our local and national communities around policy, education. 2, being a hub, a repository of maternal health data around the distribution of severe maternal morbidity, maternal mortality. And 3, advocating and fighting for a space where Black and brown birthing people can safely, efficiently receive the quality access to healthcare that they deserve. So these are some of my students in my research lab. Actually, Heather, who has her hand on Amaya's shoulder, is a doctoral student here at Harvard in the School of Public Health. And so we do a lot of amazing work in 3 key areas: research and science. We also focus on community engagement, advocacy, and policy. And we have a marketing committee which focuses on getting resources and information out to our broader audience. I think I'm right at time. Here's my contact information. If everybody wants to contact me, I'm happy. I'm looking forward to the Q&A. Thank you so much.
Thank you very much. Dr. Anderson, floor is yours.
Thank you. Just thank you to everybody for inviting me to be here. It's really wonderful, and it's really an honor to come back to Boston and see old friends and make new friends as well. So I'm going to be talking about minority stress and being LGBTQ+ in America, and talking a little bit more about how minority stress affects mental health in LGBTQ+ people. Just it's something I do as a trigger warning for people. I'm very open about my own mental health. I live with a history of depression and suicidality. Those are both in remission at this point, but I just always like to give people that background, because also no question is off the table for me. And also these are topics that can be sensitive for a lot of people. So I think it's always important to mention that at the outset. In terms of an overview, part 1 will be terminology for the discussion, and then part 2 will be in America for LGBTQ+ people. We're going to do a little bit of past and present. That should be part 3. Don't tell people at MIT, where I graduated from, that I can't count anymore. They will revoke my degree. We are going to talk about what is minority stress and delve in a little bit more. Part 4 will be minority stress in America and in healthcare, so some statistics to keep in your back pocket, and things that when people say, like, discrimination doesn't happen, you can be like, here are these studies about this. And then part 5 will be how can minoritized people protect themselves. That's something that I have added to this talk as time has gone on, because we do not do enough teaching about how minoritized people can actually look after themselves. So in terms of terminology for this discussion, a lot of you have probably heard these terms before. The first is cisgender, so sex and gender identity are seen as the same, or felt to be the same as well. In terms of gender, this is socially constructed, so these are attitudes, roles, behaviors, activities, things of that nature. Gender identity, so individuals' own internal sense of self, of being a man, woman, non-binary, etc. Gender expression is how other people see your gender, or how you express your gender to other people. So this can be hairstyle, clothing, voice, like my hairstyle and things like that, as well as other characteristics to express one's gender to others. Gender dysphoria is something that we talk about specifically for transgender individuals, as well as gender non-conforming individuals as well. So this is psychological distress due to gender identity and assigned sex. So sometimes that incongruence can cause people to have mental health issues and mental health struggles. There is also a new term that's coming into being, and it's called gender euphoria. So that's when those things, those aspects of yourself match, like when somebody actually uses the proper pronouns for you. Those things induce gender dysphoria, where you feel seen and heard. There's also sex, so biological status as male, female, or otherwise. And then transgender, so your assigned sex is incongruent with your gender identity. There are a lot more terms, but I wanted to keep it short for everybody just to bring us onto the same page. So part 2 will be in America for LGBTQ plus people past and present. So this is in terms of finding safety for transgender people right now. We've seen different maps that show this in different areas. So what is happening is that transgender people and people who are gender diverse actually are looking at these things. They're saying, where is it safe for me in the next election cycle to live? Where is it safe for me to get health care? Where is it safe for me to get mental health care? Where is it safe for me to exist as like a human being? I want you to know, as a child and adolescent psychiatrist, all of my kids who are transgender have seen something like this. This goes from like ages 7, so some of the kids who are transgender are coming out really early. They are reading these things on the news. They are thinking about safety. They're thinking about, where can I go to school? Where can I go to college? Where can I have a job? Where can I exist as a human being in a society that is not protecting me in the way it should be? So we've seen basically maps similar to this, but across the country there are anti-transgender bills that are being introduced across different states. So I wanted to show it's not only in terms of like athletics, but it's also in terms of other bills and things like that. So you're seeing this is happening across the country. So we have something that we have to deal with, and this is pretty enormous for a lot of the people I work with. This is something that they wake up and start thinking about on a day-to-day basis. This is something that they wake up and they say, I have to contend with this in addition to going to school, in addition to just like talking to my parents and saying hello in the morning to somebody. So I want to take us back a little bit. So not that long ago, when I was just a young adolescent and I was applying to college, I had to think about these things in terms of same-sex marriage. So I identify as gay and non-binary and African American. As a gay person, when I was applying to college, I had to think to myself, what state is safe for me to go to college, and where can I maybe get married? I already had to start thinking about that. So that was at age 17. Massachusetts was the only state at the time. So we were playing out very similar cycles in how we do things. So that's something to keep in mind. Can we learn a little bit more quickly, and can we help people a little bit more quickly as we see this happening? And so yes, that changed over time. Things got better. Now we have gay marriage across the country. We know people are attacking that right now, but times did change. And what has been mentioned in the presentations before mine that were all very eloquent and wonderful is that knowing people and having visibility actually helps progress that change and move it forward more quickly. So that's why I decided to do these talks as like somebody who stands in front of you who is minoritized and says, this is how this impacts people directly. So part 3, what is minority stress? We had a little bit of an introduction to that earlier. That was really wonderful by Dr. Moon Moon. So we're gonna go into it a little bit more. So the typical definition is the process through which stigma directed towards sexual minorities influences health outcomes. This can be physical and mental health. So Dr. Meyer came up with this term. It actually came into being a little bit earlier, so in the 1990s, and even before that, other groups were studying this from a sociological perspective. However, Dr. Meyer, when he wrote his first article about this, it didn't land as much as he wanted it to, so he reintroduced it in 2003, and then it became a seminal paper. So sometimes in academia, just redoing your same experiments in different ways actually gets you out there in the ways you want. So just something for us all to keep in mind. However, he was actually studying LGBTQ plus populations at that time, and so he wasn't looking at other racially minoritized groups or anything like that. And what happened is that other minoritized groups said to themselves, oh, this definition actually fits us as well. So out of that came minority stress theory, so this is known as the more elegant explanation. So individuals from oppressed social groups experience excess stress and negative life events because of their non-dominant status or statuses, which can lead to or exacerbate mental health problems. These effects are unique, socioculturally based, and long-lasting, which means they can be additive or multiplicative. So the way I like to describe it to the kids that I work with is imagine getting a paper cut. You get one paper cut at the beginning of the day, and that's like somebody saying a racial slur to you. It's annoying, but you're like, I can maybe patch this up, I can maybe heal from this. Now imagine getting 1,000 paper cuts per day. You don't know where those paper cuts are coming from, who they will come from, if they will be from your own classmates, if they will come from your parents, if they will come from teachers. So you eventually end up with a bunch of cuts and you don't know how to heal yourself anymore. The other way that I think about it is I like to watch a lot of Sailor Moon, the old Japanese version, because it's amazing. And so she has this thing called the silver crystal, and it encapsulates all of her power and her identity, basically. So imagine getting a crack in that shine. And so you get one crack, you're like, I can patch this up. Then what happens is if you get 1,000 paper cuts or cracks that day, then actually your shine shatters. And so that's somebody who is minoritized, that's their sense of self shattering, and they don't know how to put themselves back together again. That leads to negative mental and physical health outcomes. This also comes along with institutional discrimination. So these are disparities that systematically favor certain groups. So this can include housing. So back in the day in Chicago, there was this thing called redlining. And so what that was African American people's houses were appraised at different rates compared to white people, and African American people could only buy homes in certain areas. So this actually plays out. This is still happening inside of Chicago, inside of, if you think, oh, houses are appraised in America in general. This happens even in San Francisco, which likes to think of itself as a very liberal bastion, which they are, and there still is work that we need to do. This also includes schooling, employment, health, and justice. So this is a slide that actually shows minority stress, and so what I want you to think about is minority stress actually starts externally for people. So I wanted to dig in a little bit to show you how this plays out. There are these things called distal stressors, so what I want you to think about is these are outside factors that then influence your internal factors. So some of the distal stressors, or things that are outside of you, can include gender-related discrimination, so difficulty with getting health care, gender-related rejection, so that's including your parents not being accepting, and then that can lead to also gender-related victimization and non-affirmation of gender identity. This then leads to proximal stressors usually for people. So these are things that then become internal. So when you have an external thing that is affecting you internally, you take that on and you have to shoulder that burden as well. So these can be internalized transphobia, negative expectations. So even meeting somebody new who is not transgender, you expect that they're going to react negatively to you. And also non-disclosure, so I don't want to share my identity. Then that leads to these mental health outcomes and physical health outcomes that are negative. So depression, substance use, anxiety, higher rates of heart disease, and things like that. While I'm loath to use the word resilience factors because we usually say, like, if somebody was more resilient, they'd be fine. We're going to use that because that's the terminology that is used as of right now. So what can stop minority stress actually are things like pride, so feeling special and unique about one's gender identity. So some of those things like gender euphoria, where you are actually affirmed inside of your gender. And then also community connectedness. So these are two of the things that are the most protective things that are being studied in psychiatry that can help mitigate minority stress for people. So the kids I work with, I ask them, like, what is your community like? What is it like to be LGBTQ+? What is it like to be racially minoritized? Do you have a community that supports you? Because those are the things that can help your mental health overall. So, minority stress in America for LGBTQ+ people. In terms of statistics for LGBTQ+ people, youth identifying as LGBTQ+, they do a study that's biannual across America. So all sexually minoritized adolescents reported higher rates of violence victimization. This included feeling unsafe, forced to have sexual intercourse, being threatened with a weapon, being bullied at school or online. In terms of being bullied at school for gay males versus heterosexual males, the rate was 27.7% versus 14.6%. That's almost double. Lesbians also reported higher use of cigarettes and marijuana use, and the prevalence of cocaine, heroin, methamphetamines, ecstasy, and inhalants were higher in sexual minority groups. One of the things I always think about as a psychiatrist is somebody is using substances for a reason. We very much stigmatize people who are using substances, and our job as providers and as people in general is why is that person using substances? Why is the most important question that we can ask inside of psychiatry and in the general populace, because that gives you a context of this person might have been coping with something that they didn't have other coping tools. So sadly, this plays out inside of the prevalence of suicide attempts as well. The statistics on the right for heterosexual people will be a little different because they're looking at different high schools. For lesbians and gay people, the prevalence of suicide attempts was 24.3% versus 13.1%. For bisexual people, it's 28.3% versus 23.2%. For people who said they were unsure, the statistics actually reverse. So it's 12.4% versus 14.9%. The reason the statistics reverse when somebody says they are unsure is because kids who are LGBTQ+ actually know their gender identity or that they're LGBTQ+ very early on in their lives, so 5, 6, 7, usually before their heterosexual counterparts. That is a double-edged sword. It actually gives them a sense of self that is very strong, but it exposes them to a lot of discrimination because they are maybe displaying stereotypical behaviors that other kids or adults actually will go after them for. In terms of drawbacks of the study, so they saw high dropout rates, and they actually think there's an underestimation in the rates and prevalence. If you think about it, if a kid comes out when they're really early, and like they're 5, 6, 7, they're actually exposed to discrimination earlier. So some of those kids don't actually even go to high school because they say, I want to be homeschooled, or I can't go to school anymore. Or as we talked about, they suicide at that time. We don't say commit suicide anymore. So since the 2016 election, this has actually only gotten worse. So the FBI keeps track of the hate crimes that are reported across the country. And so what they're seeing is across racial groups, across LGBTQ+ groups, and people who are minoritized in other ways, the politicians that we have in office are very important because they set the laws and they embolden behaviors if they aren't doing things appropriately. So we have a lot of work to do. In terms of statistics, go ahead. Oh.
You're at time.
Oh, I'm at time, okay. Okay, all right, thank you. So this is obviously all these things are pretty big. So there are actually techniques for protecting oneself that prove promising. So reflective coping and problem-solving activities is really important. There's 134 studies about discrimination and health outcomes. These include things like cognitive restructuring, expression of emotion, and social support seeking. And also the importance of community is very important. There's also specifics, so I'm going to jump ahead, but the American Psychological Association made an actual chart of saying how to deal with discrimination. So these are things like making the invisible visible and disarming microaggressions. So this is with special thanks to everybody, and just thank you.
Great job. And now it's my pleasure to welcome Dr. Van Susteren.
Thank you very much. It's great to be with you. I'm sorry I can't be there in person, but very, very appreciative of being able to Zoom in. So the gender gap, disproportionate impacts of climate disruption on the mental health of women and girls. Any physical injury or loss carries with it an attendant psychological toll, and any psychological injury carries with it an attendant physical toll. It's a two-way street. I have 2 points to make today in this short segment. 1, awaken our sensitivity to the climate crisis on women's and girls' mental health. This is a global phenomenon, but I will be describing conditions and citing data primarily from developing countries because it is often more apparent. 2nd, I would like to bring up a novel question to consider. Is a woman's style of leadership particularly called for in this era of divisiveness that keeps us from the urgent need to act collaboratively on climate? Point number 1, women and girls' increased vulnerability to the consequences of climate disruption is driven by multiple factors. Social, that means structural; cultural, that's what we internalize from our surroundings; economic; and political. Here's what we know. The majority of the world's poor, over 1 billion people who live on less than $1 a day, are in developing countries, and the majority of the world's poor, estimated at 70%, are women. Particularly in developing countries, women have reduced access to credit, to decision-making, to property, technology, education, and other goods and services that would enhance their protection and capacity to adapt to the demands of the growing climate crisis. These demands, we know, hit the poorest the hardest. Women are disproportionately dependent on natural resources at risk from climate disruption, especially pronounced in rural areas where women are charged with making the long and sometimes longer and dangerous trek as a result of climate change to obtain water and energy, usually wood, to burn for cooking and heating. In areas of sub-Saharan Africa and Central America, women disproportionately scrape by as subsistence farmers. That is, they use all that is produced from crops or livestock that they themselves produce to survive. There is no surplus. Extreme weather events, never mind the chronic conditions of drought, sea level rise, and global overheating, affect the health, wealth, and safety of everyone, everywhere. In the aftermath of extreme weather events, with its attendant injuries and deaths, damage or loss of home, property, the comfort of familiar daily life, and the disruption of communities, studies in the US show an increase in major depressive disorder, generalized anxiety disorder, post-traumatic stress disorder, and domestic violence, and this includes child abuse. There is no reason to think this is different in other countries. In developing countries, in the aftermath of an extreme weather event, women and girls are less likely to have access to the resources, food, medical, and other material that will help them recover. This deepens their vulnerability to future events. In developing countries, women and children are 14 times more likely to die after a disaster than men. More than 55% of women in Africa, at least in 2000, were unable to read, compared to 41% of men. Not being able to read presents additional impediments to getting help and indeed to learn of preventive or adaptive measures that might be taken. In times of drought, storms, floods, fires, and searing temperatures, the increased challenges to find resources and safety, the activities of daily life that women typically bear, mean they have less time to go to school, to learn new skills, or receive training to advance themselves, to pursue other opportunities. A global stat we know, one standard deviation increase in temperature increases violence 4% between individuals and 4% between groups. This is true in all regions of the world and across all ethnicities. This means an increase in assaults, murders, and suicides. Conflict-ridden areas spawn more gender-based violence, including sexual violence, human trafficking, and child marriages. Extremes of heat increase the incidence of stillbirth. Climate disruption is a key factor in the spread of vector-borne diseases such as malaria, dengue fever, and Zika, all examples of conditions that harm maternal and neonatal health with the obvious attendant emotional toll. In developing countries, women are primarily responsible for food production on the order of 50 to 80%, but they own about 10% of the land. An increase of 1 degree centigrade on average reduces agricultural output by 10%. The crops most affected are those the world's poor are most likely to depend on: corn, maize, wheat. And food shortages are most likely, therefore, to affect women. Additionally, higher concentrations of CO2 from burning fossil fuels results in less nutritious food with physical and cognitive impacts and mental health impacts, even starvation. And while fathers also feel the anguish, of course, it is usually women who tend to members of their family who are ill. Cultural norms in many countries impede women from leaving at-risk areas or even escaping acute weather events. As the principal caretakers of children who accompany them, it's harder to move to safer, healthier ground. Fertility has dropped an estimated 50% in European, Australian, and American men. Africa was not studied due to funding and other challenges. Exposure to chemicals can damage sperm and reduce sperm count, dubbed environmental castration. But alarmingly, research shows that extremes of heat also reduce healthy sperm count. Fertility in women is likely affected, but we don't have the studies yet. Overlooked, and I had personal experiences when I worked in West Africa as a doctor, is the anguish of women who are unable to conceive, Particularly, although not exclusively, in developing countries, women are blamed for infertility and they are shamed for it, bringing a lifetime of personal humiliation to themselves and often by extension to their families. Briefly, point number 2. The following isn't one sex is better than the other. It isn't even, as one person once said, one is more deserving than the other. And I haven't seen a call to action that I'm going to make at the end written anywhere else. Men and women have different leadership styles. I'd like to make this point, maybe disguised as a question. Is a woman's leadership style better suited for our needs, or maybe desperately needed in this era where collaboration is essential if we are to take action on climate change in time? In the old days, physical strength conferred an advantage. In the absence of labor-saving innovations and devices, it made us better at getting food, materials for shelter, fighting off aggressors, etc. Patriarchal society, we might imagine, emerged as a result. With our now technologically advanced and vastly more socially complex world that calls for a deep sense of empathy, is that patriarchal structure less desirable? Patriarchal leadership is associated with command and control and inspires progress through competition, creating winners and losers, insiders and outsiders. Money, status, access to special information, and access to the leader are awarded based on hierarchical buy-in, allegiance to the leader, and adherence to what the system demands. Work relationships are transactional. Women's leadership style strives for collaboration, typically with a horizontal organizing structure that promotes grassroots buy-in, that establishes a feeling of egalitarianism, of valuing all opinions, of sharing knowledge and sharing power. Empathy over stark competition is emphasized. All boats should be raised. Work relationships, ideally, are transformational. As we look at the divisiveness and rigidity of established political models and entrenched business practices in a world riddled with climate dangers and close to tipping points, dissension and resistance to change, along with growing inequality and rewards, the disproportionate opportunities for the privileged and those in power, do conditions not cry out for an increase in and emphasis of women's style of leadership? Coincidence? Here in Massachusetts, where you have the nation's first cabinet-level climate chief to oversee an all-of-government approach, your governor is a woman, your lieutenant governor is a woman, your state senate president is a woman, and your new climate chief is a woman. I'd love to hear your thoughts. Thank you.
Dr. Van Susteren, you may have not been able to hear it, but just before you finished, there was about to be a round of applause. So I just want to make sure that you know that. All right, so we're going to start the Q&A portion now. I see questions coming in. Encourage anyone in the room or anyone online, please send in questions. We'll try to get to as many as we can. I want to start with the first question to you, Dr. Anderson. So you started very honestly by saying you've had your own struggles. And so can you give us a sense as someone who has had your own struggles, but is also a working psychiatrist, how do you take care of yourself? But then also, in your work, what do you see as some of the most rewarding parts of it?
Yeah, thank you for the question. And I think one of the things that I do to protect my mental health is I take medications and I go to therapy every week. I think that is an integral part for me. It is not for everybody, but it is for me. And one of the other things I want to point out is that I've learned a lot of these techniques over time. I teach kids these techniques now, and they're evidence-based and things like that. But when I was growing up, I had to learn these things on my own. And so for me, one of the big things is community. I actually got here early just to see my old friends from MIT. So we all hung out and I had 11 social events. That was like way too much as an introvert. I know better now. But seeing them, they changed my life and saved my life. So that connectedness, so that minority stress thing that I was showing, we somehow were figuring that out on our own back in the day. And then the other thing is, for me, an important part of my mental health is to help other people with their mental health. So that's why I'm a child psychiatrist. I want to create a space where kids who are LGBTQ+, who are racially minoritized, they might have a safe space earlier on than I did. So that's also how I protect my mental health, is by giving back. And the most rewarding things that I've seen are actually the kids as they get older. They are learning techniques earlier. They are learning ways to protect themselves earlier. I remember when I started teaching about minority stress to the kids that I worked with, and one of the first kids started crying, and I was like, I'm gonna get fired. And she was like, no, the reason I'm crying is because this has been my whole life and nobody gave me the terminology for it. And that kid started using some of those terms, and I could hear them when they were interacting with other kids, teaching them about that. So I have seen kids get better just by having that space and having an adult who says, I see you and I care about you and I love you in a deep way because you are going to be amazing. That can change a kid's life. So there are studies from the Trevor Project, just one accepting adult can reduce suicidal ideation by 40 to 50%. So we have a lot of power in this room just by us being ourselves for people.
Thank you. So I want to turn to you. Yeah. And I'm actually going to save some of my questions because there's a lot coming in from the audience. I want to make sure that we get some. So I'm just going to ask one question of each panelist. But one thing that's really important as we think about maternal health outcomes is not just how bad they are, but how do we drive towards solutions. Right. So as you think both about maternal health outcomes, but also postpartum depression, which is squarely in line with the theme of today of mental health, what do you see as some of the most promising solutions?
Thank you for the question. I think a couple things. One, centering the role of doulas. I think doulas are incredible resources. I think postpartum doulas are amazing in really providing ways for women to be connected in the postpartum period. We don't do a good job of doing postpartum follow-up. You get one appointment 6 weeks after you've given birth. By then, you can't even see straight because the baby has consumed your life. But you get one appointment. And I remember my postpartum visit, and it was all about the baby. And I was like, well, the baby has a pediatrician. What about me? And so I think we need to do a better role of centering the role of postpartum doulas. I think they're an incredibly underutilized asset.
And Dr. Van Susteren, so from where you sit, I've got two very different questions for you. So I think that the audience might be interested to know that you are currently working as an expert witness on psychological damages to young people for cases that are pending against the federal government and in Montana. And so can you tell us a little bit about those cases and what you're hoping to accomplish?
Well, how long have I got? All right. First of all, the case that you speak of that's against the U.S. government is Juliana versus the U.S. government, 21 youth plaintiffs. Well, they were youths, but they aren't many of them anymore. And the climate scientist, Jim Hansen. The government, U.S. government, is being sued based on constitutional grounds that we are guaranteed the right to life, liberty, and property. And many of these kids have lost homes and other property as a result of inaction on climate. So we're suing them, and not sure when the case is going to come up, still bouncing around the court system. In Montana, there are 16 youth plaintiffs suing the state of Montana once again on Montana's constitutional grounds. And in Montana's constitution, it states explicitly that the citizens of Montana have a right to a safe and healthful environment. And it's anything but. It's a bonanza for the fossil fuel industry, for exploration, drilling, extraction, and transport of fossil fuels. And the kids, I mean, I'm not speaking of them explicitly because I'm not free to, but the audience knows it's not fun to think that, the world is reaching tipping points and that leaders, rather than helping us to prevent the dangers, are contributing to them. So that's the essence of the cases.
Let me stick with you and go to one of the audience questions, which is, and then I'll turn to you, Dr. Anderson, for your thoughts. Can we do the women's leadership style structure in the mental health professional community? The community is top-down and too, quote, disorder and diagnosis focused. So how can women leaders help in this space?
Oh, boy. Well, first of all, if you're not, as I've said in the past, if you're not a burr under someone's saddle with respect to climate several times a week, painful though it might be, we're not doing enough. We are so very close to tipping points. And when you look at the impacts of climate disruption on the mental health impacts, on the toll in people, what could be more important than speaking to our colleagues about addressing these issues? I have to say, when COVID was just beginning, my colleagues came out in droves talking about mental health consequences. But kids are talking about their anger, their despair, their fear, the belief that maybe the world isn't worth living in, and maybe not certainly worth having kids, et cetera. We, as mental health professionals, should be at the epicenter. This is what we do. We change behaviors today so that people down the road especially, but now too, don't suffer as a consequence. And we know how to burrow under defenses. We know how to get people to trust us. We even know how to find a silver lining in times of great darkness. This is made for us.
What do you say, Dr. Anderson, about women in mental health?
I mean, more, please. Like, we need this. Men need to get out of the way because we had our time and didn't do a good job, so we need to fix that. But to be a little bit more, like, not as flippant in some ways, I would say that one of the things that we need to do is think about the hierarchy you mentioned from the top down. And so where are women in leadership? Why are they not being, like, why is there not a pipeline for women to be in those leadership positions is what we really need to start thinking about too. You can't just bring in women who are like going to be trainees and not give them the power to actually reach that echelon. Why are you not bringing women in at the top leadership and replacing people who have discriminatory behaviors or problematic behaviors? That also goes along with the hierarchy. Everybody feel free to call me Chase. That actually like helps with reduction of hierarchy and things like that. We are all colleagues. So how do we change that conversation inside of the hospital too of like, we are all colleagues, we all work on the same team. That applies to the world. We are all here together. In terms of also, you mentioned the question about mental health and diagnosis and things like that. And so one of the things I want us to take a step back and look at is we make a lot of assumptions. The DSM makes assumptions that somebody wants to call this depression, that these criteria fit this like name. What I actually work with kids around is, yes, you have these symptoms and they represent this inside of this book that we have, this old book that like a bunch of people create and they think it's like the end all be all. And I sit there and I'm like, that book is junk in some ways. It helps us describe some things, but I want to know from you, because you are an individual person, how do you want to describe what is going on to you? I have a kid who he lives with schizophrenia, and when we had to do the diagnosis, I talked to him, I was like, but I know you might want to call this something different. He's like, I don't like that name. And so I had to do it for documentation, but I was like, what do you want to do? And he said, I'd rather just talk about my symptoms, like I see things or I hear things that aren't there. He got better. It wasn't just medications, but just that therapeutic alliance of like, I see you in this room, I hear you is so important. And why don't we bring that to like how we do healthcare in general and respecting the women in our group, that we are coming from, let's come from a different lens because what we've done hasn't worked.
So I want to turn to you for the next question, which is there any scientific hope for a biochemical genomic basis for the effects of various minority stressors?
Well, I'm not a basic scientist, so I'm not completely sure. But what I will say is that we need hope in general as it pertains to managing stress. I think the underlying impact of stress on the body has been well documented through the weathering hypothesis, the work of Arlene Geronimus. I remember writing my dissertation on this over 10 years ago, so I think there's a nice body of work. But the first part of the question, the
biochemical and genomic basis.
Yeah, I'm not completely sure. I haven't seen any calls for that in our holy grail in my world, which is NIH. I haven't seen that, but there's still hope.
Anything, Ted?
So biological basis for minority stress, it's not as studied as it should be. There are a couple studies that are like, you have to dig a lot to find them, but basically it talks about cortisol levels and the stress like paradigm that happens for people. And so there's one where they compared Black Americans to Latino Americans to white Americans and their cortisol level, and how for some groups with stressors, it will rise and then it will come down like pretty quickly for some people. For people who are Black or like minoritized, sometimes it goes up and then it will stay up in the ways that it shouldn't. So the way I think about it is like a zebra. When a zebra gets chased by a lion, it then like actually shakes and then its cortisol levels go down. When you have like a zebra who can't do that, can't shake, then basically that cortisol level stays up, which then leads to some of the things that we've seen. But yeah, you have to dig like really deeply, and that means that we need better studies that are more out there for people too.
Dr. Van Susteren.
I wanted to just add, as I was thinking about answering that question, 2 points. One is we don't want to pathologize climate distress because it's legitimate to be distressed about what the science is telling us. But I also want to emphasize that our organizations need to be called upon to establish a subspecialty in climate and mental health. That includes knowledge and experience and training about social determinants of mental health, all the social injustices we talked about here, and understanding certainly when it comes to climate, to energy issues, to the difficulty accessing clean energy and living in safe places far from the bullseye, et cetera. Subspecialty in climate and mental health, and pushing the American Psychiatric Association, push from your end too, maybe we can get them to establish an official subcategory.
And sorry to speak over you.
No, that's all right.
Staying with you for a second, what have you seen work well in alleviating climate distress in young people?
Okay, so I have it first started off as my 3 Ps, then it was my 4 Ps, now it's my 5 Ps. Okay, first one is if you want to tackle your climate distress, certainly talking to people about who are kindred spirits is going to be helpful, because we sometimes live in a world that it almost feels like it's an alternate universe. Some people get it and some people don't. And we won't talk about resistance and denial because that's another whole conference. All right, first P is personal. Calculate your own carbon footprint. You are not going to be able to be a good advocate or talk about what needs to be done if you feel like a hypocrite. You'll understand what's hard to do, what's easy to do. You can be smart. Second is professionally. That's what we're doing here. We're talking about this and in other domains. The third is publicly. There are tons of organizations all over town, locally, nationally, and we're putting, by the way, a national climate hotline together so people can easily find an organization. And then there is, of course, a politically, get behind politicians, candidates who make climate a priority. Run for office yourself. And last, my latest 5P, it fits in very nicely, protest. Make noise. As John Lewis said, make good trouble.
Thank you. So let's go back to another audience question, and there are some great ones coming in, so please continue. So I actually want you all to think about this question, which is, can a holistic care approach help in addressing the shortcomings around women and minorities' health care in terms of advocacy or otherwise? Do you want to start?
Yeah. Absolutely. I think a holistic approach that, so back to my remarks when I was talking about the social determinants of health, that is the beginning of a holistic approach. We're encompassing and honoring and acknowledging people's fullness, including their physical environment, their housing, their education, their income, their access, their food. And that holistic approach is absolutely what we need to be able to deep down make a difference. If we're only treating people at the top level, we're only treating people when they present in the ER or they have complications, we're missing the majority of that person's life and experience and not able to make the type of care that we need to make stick.
Chase?
So I want to say people are not their medical illness. People are not their diagnosis. That is one facet of a whole person. There are actually studies that were done in terms of, they looked at African-American college students with people who were white psychologists, And if the psychologist did not address the fact that the person was African American or might be going through racism, they actually saw a higher dissolution of care, so not wanting to be in care, or they felt like things were being missed in terms of actually dealing with what they were going through. So I think the holistic approach is the most important approach, and I'm going to take a personal perspective. I have seen my patients get so much better when we respect all facets of their identity. Mm-hmm. People are going through enormous things. They got to that office through some route. And so we take a very deficits model in medicine sometimes. What are the strengths? What are the aspects to them that really got them there? How do we start to highlight those? And how do we help them feel like a whole person inside the room with us as well? Is really important.
How about you, Dr. Van Susteren? What would you say?
Well, there certainly agree globally that a holistic approach is always just like an all-of-government approach. Sometimes when, it's that story of the lineman and the elephant outside, each one describing the elephant, the trunk or what the leg looks like or the tail. And if we don't have a holistic approach, so often we find that we're leaving behind critical issues that we hadn't thought of, and we're treading in areas that end up backfiring because we can't understand. That said, it's also important that people recognize that each of us has certain strengths and weaknesses, and that valuing also what people are good at and what they feel most passionate about, often, referring to some perhaps personal experiences, is important too. So, we really, I think, need both, but of course, in the end, it's the all in the arena approach.
So the next question has a warm place in my heart because I'm from Baltimore. We always say y'all. And this person asked y'all up here a question. But essentially the question circles back to what we were talking about before, which is having more women in leadership positions. But what if you have more women in leadership and they're not listened to? How do we deal with that? So I'm going to turn that to you.
Well, first of all, shout out to Baltimore. I did my postdoc there. I love Baltimore and Lexington Market in particular.
Yes.
So if women are not listened to, that's nothing new. I think that's part of what we are saying every day. I think the way to make inroads is to just do the work. I get this question a lot. Like, I feel like, in my space, I'm not able to make the inroads. I'm like, you do the work and people will come around. I really feel like that. When I got to Boston in 2017 and started doing Black maternal health work, it was pretty dry. And now that I've been here for a few years and I'm seeing that there's a real movement and a passion, the work that I'm doing is getting traction, the conference, the students I'm able to train. And so that's how you get people to listen to you, is by doing the work from your heart, from your gut. And people will come around because the train is moving, so they can choose to get on or not. Dr.
Van Susteren, women in leadership, making them feel heard.
Well, and still she persisted. I've been in the climate battles for a long time. If there's one thing I've seen that works, it's perseverance. And frankly, I quoted John Lewis just a minute ago. It's making good noise and doing it again and again. And certainly it's true that culture, it reflects the people that are in it. And it's harder to break through when you are a minority, whether any type of minority. But that doesn't mean it can't be done and shouldn't be done. And, they always say sometimes it's darkest before dawn. You never know when you're going to reach a tipping point, and it doesn't have to be to change a culture. I've heard numbers, all you need is 10%. And I heard somebody say 25%. There's a famous professor there at Harvard who has talked about what political revolutions require in terms of numbers. Doesn't have to be everybody. But it does have to be people who are persevering and people who screw their courage, as they say, to the sticking place. And above all, they put their voices together. So women are usually good at forming collaborative groups. And I think that that's where our power is, along with our persistence.
So you talk about making good trouble. And I think that and you raised the topic of structural racism, which is pervasive. It affects every aspect of American life. It certainly affects mental health, but it's a tough topic to talk about. So I'm curious, and I'll start with you, if I may, in the work that you're doing, how do you raise the topic? How do you make it real for people? And how do you integrate it in everything that you're doing?
You know, I think there's a way to talk about it, and I give a lot of talks, and I think what I've noticed is people are more apt to understand, digest, acknowledge it when it's presented to them in a way that's not like accusatory. It's not like, you're a racist person. It's like, we're talking about a system that you may or may not have benefited from unmeritoriously, right? Like, that's really how racism works. It doesn't really help anybody at the end of the day, because everybody is in it for whatever positioning that they were born into or bred into, et cetera. So when you present it in a way that kind of takes the focus off the individual, I think you're able to get a lot more traction. And frankly, it's not a place to stay. It's a place to acknowledge the system is racist, the system is broken and fragmented, but here are some solutions that we can implement that will make better outcomes. It's always about moving towards solutions. Everything has to be from an asset-based perspective. You can never sit and say the glass is half full. The glass has to be always full. And that's the lens that I take when I talk about it. I talk about racial equity as being a process and an outcome. It's a process. It's an evolution. But it's also an outcome. When you achieve it, everyone is in a space of winning together. And so that's how I approach it. It's a real delicate line, because I think the initial response, if you've never had to sit in your privilege, if you've never had to grapple with white fragility and oppression and microaggressions, it can be like, oh my gosh. But I think when we talk about it in a way that honors the fullness of how racism impacts everyone, people are more likely to digest it.
Mm-hmm. How about you, Chase? Structural racism in your psychiatric practice?
Yeah. So I think the thing that I do is I blend emotions and facts. That is the thing that I've seen help people the most. When I used to come at it from emotions, I was like, racism feels like this. And people would be like, you're being oversensitive. And then I'd be like, that didn't work a lot of the time. I have left other universities just being open because I couldn't move the needle enough, and I couldn't move it with other people. What I've had to learn is that if you do facts along with emotions, that's really what gets people. So that's why my talks have actually changed as time has gone on. That's why I self-disclose, because I'm saying, like, this is somebody standing in front of you with mental health, and I am still here. Now here are some facts about like how we got here. So that sticks for people a little bit more, and so it actually has changed how I come at things as well. And then with kids, I do like the facts and emotions too, to start training them early about this is a way that like you can get through to people. So maybe your parents understand a little bit more about you being transgender, and here's some stats around it, but also like here is like you being you as a person, and let the adults also like, I will help with your parents too. So that's how I come at things now.
Mm-hmm. Dr. Van Susteren, structural racism and climate.
Oh, well, I mean, it's very, very clear that those who have the least privilege in our society, the least power, et cetera, will be the most disadvantaged as time goes on. And this is something that is certainly talked about within my circles, climate circles. And it is obviously something which is deeply painful. And, you know, for some of us, including me, you know, at the worst, I think to myself, as the world grows, the gap between the haves and the have-nots, and recognizing how unfair things are, you know, the pain really, and I'll join you all in saying I've got what I've dubbed pre-traumatic stress disorder, which is I think about these things all the time, even though I may not be on the bull's eye, but I certainly have all of the criteria, or many of the criteria that you can hear about with post-traumatic stress disorder. And I do believe that it is very true that when you talk about your personal issues and you talk about how painful it is to see these injustices, and you speak about it not in terms of a number, although data establishes you as an authority, but with either a personal narrative or stories that move people's emotions. So an interplay between both is a way to get them to start thinking and feeling. And with that, of course, prompting them to begin to take action. Now, I will also say that, look, we're a herd mentality. What we see the people around us doing is what we adapt. We self-report that we're independent, and we make our own decisions and all the rest, and that we don't follow others, but it's just not true. Studies show that we are most likely to do what we believe other people like us are doing. And when we make that appeal and start talking about social norms and how this is what we expect from a safe and just society, this is how I certainly don't like to say over time, but cultures, the ship of state does turn slowly, but just as there are climate tipping points, there are social tipping points. Let's hope we're getting closer to them.
So sticking with you for a second, one audience member posed the idea of a universal basic income, the concept that everyone will get a base amount of money to ensure sufficient services. Could that be a viable political strategy to help with structural racism?
You're asking me that?
Yes.
Oh, gosh.
And then I'm going to ask both of you that.
I'll go first. I'll tell you that I am averse enough in, is it a political decision that would work or a social decision? It's not where our country is right now. I can certainly assure you of that. The reasonableness of various political actions is different from what is realpolitik. In other words, what it is that we can imagine happening today. One of the key things, really, if we want social change, is to get, is when I said political, one of those P's, get out there and vote and make sure that everybody votes too. Because if you look at the numbers, if the people who generally support the issues that we are promoting here today would vote, we're going to have the representation, and it's those upstream impacts that determine the downstream broader impacts.
So before I turn to the two of you on the universal basic income question, I want to give you all three a heads up that my last question is going to be asking you to think about at the intersection of mental health and the social justice issue that you're representing here today. What do you want to be the main takeaway for folks in the room? But first, universal basic income, Chase. How do you think about it?
So I wish I knew more about economics, first of all, but there are actually studies about universal incomes in different countries and how that helped with mental health and giving the right supports. The thing that I want to take a step back about is I think all of us look for that silver bullet of like, let's do universal income, let's do mental health access, let's do X, Y, Z. Why are we not saying X, Y, Z, A, B, and C? We need a multi-pronged approach in order to help people. If you give somebody a universal income, how are you actually do they have social services? Do they have what does housing look like to them at that point if you give them a universal income? What does it mean for them to get a job? Are you giving them a house and they don't have a job? So we need a multi-pronged approach on that respect.
I've been struggling with how to respond to this question because universal income does not, it might work in other places where racism is not so pervasive, but in the United States, I still think that we're not in a place for minoritized communities to actually benefit from, quote unquote, a level playing field. I think, I'm thinking about generational wealth, I'm thinking about residential redlining, I'm thinking about, all the things that have widened and continue to widen inequities between a have and a have not. So I don't know if that would work here, particularly as it pertains to maternal health inequities.
Thank you.
Yeah.
Dr. Van Susteren, this is your final word on a main message to the audience about the intersection between climate distress and mental health.
Can you say a little bit more about what exactly certainly climate distress deeply affects our mental health? And there's maybe I'll just take off a little bit with a little bit of a riff, and that is that the danger really of the biggest danger for me is how climate distress is going to affect our mental health and really erode the social fabric in so many ways. Certainly it will worsen inequities. And my primary concern, I worked for the federal government doing psychological profiles of world leaders. And one thing I know is that when people in society are afraid and society begins to fray, People are not using their best judgment. When they get stressed out, the lights go out on their prefrontal cortex where they're thinking and judging, judiciously making decisions in their moral compass in favor of survival. And what they are prone to then is the promises of tyrants and bullies who will tell them that they will protect them, and they will exchange their deeply held values, their cherished beliefs about justice, about democracy and freedom and equality, in favor of promises for protection from people who are themselves power hungry. And so we got to get climate justice and climate action right.
Thank you. Final word on reproductive health and mental health.
Well, I think we have a tremendous opportunity. The first thing I'd like to highlight is that we need a more diverse workforce. We do not have enough practitioners of color in the space of mental health, licensed clinical social workers, therapists, coaches, counselors. So I think that's the first place to start is how do we get more culturally congruent care? How do we have providers and patients on the same page? So that's one thing I'd like to lift up. Also, the need for more screening, the Edinburgh Depression Scale and all these other metrics that we use, which frankly, I don't know if they are as culturally responsive or culturally tailored as they need to be to really capture the full magnitude of what people need, particularly minoritized and Black and brown communities. And then around stigma. I mean, I started off my career working in HIV, and there's still so much pervasive stigma about accessing and staying in mental health treatment and care, and I think that's a real missed opportunity for Black and brown communities. And back to my topic about doulas and just how incredibly important they are, particularly in the postpartum period. I think if we can get some of these things right, more providers of color, having doulas at the conversation table, less stigma, and more accurate treatment and referrals, we will make tremendous inroads, and frankly, we will save lives. 22.7% of maternal deaths are attributed to mental health complications.
I know that.
Yeah.
Final word.
So I think some of the things we need to think about are advocacy, and that can look different to different people. I know some people say, like, go out and protest. That scares the living mess out of me because there are police people around, so I don't go to protests anymore. I write op-eds instead. So advocacy can look very different. I used to be active on Twitter and things like that. So what is your form of advocacy that helps your voice and helps you feel comfortable as you try to tackle the issues that are important to you? I think the other thing, you were mentioning research, and I love that. Where's the research for us, by us,
right,
and the funding,
right,
as well. And then also, how are people leveraging their privileges? I sit here with a lot of privileges, even though I am African American and gay. How do I leverage those privileges for other people? Because that is important to recognize, and be okay recognizing everybody has privileges in different ways. It is okay. And then I think the last thing, this is very much my wheelhouse and what I do, but and you've heard me talk before, but why are we not dreaming a little bit more? I think we have a society that we are in really hard times. When did we stop imagining a world that could be much better, where people are actually fully accepted for who they are? When did we stop imagining that we could get to that world sometimes? So I think that's the last thing I would leave people with, too.
And a perfect place to end.
Perfect.
You know, one of the great things about Radcliffe is it's possible to bring together very, very diverse topics into a single conversation, and I think this really nicely illustrated that. So thank you for your really good attention, and please thank the panelists.
Thank you. Thank you. Thank you.
Thank you, Sarah. Thanks to the speakers. Once again, the theme of stats and narrative came through, right? Data and emotion is the most effective. And I just want to maybe answer that question related to the genomic bio question and psychosocial stress, because I have some experience in that, because I do research on that from a basic science. And there is epigenetic data that supports the impact of psychosocial stress, and it's real.